Morning everyone, I almost said afternoon then. My name is Gemma Mason. I am the Clinical Account Manager at Fresenius Kabi. I'm here to talk to you about the development of our specialist national clinical account team and the impact that had on contingency management. So just quickly, Fresenius Kabi, we are a global healthcare company specialising in life-saving medicines and technologies for infusion and transfusion and clinical nutrition. And what I'm going to talk to you about is our clinical nutrition area and parental nutrition predominantly. So next slide, thank you. So under the umbrella of Fresenius Kabi is the Kalea Nursing Service. We have a national community nursing team with 5 geographical nursing directorates across England and Wales. We have at the moment 439 parental nutrition patients receiving nursing visits for disconnections, connections, some or all of their care, split between adults and paediatrics. We also have a home therapy immunoglobulin service, as well as a biosimilar service. Next slide, please. So within the Kalea Nursing Service sits the role of the clinical account lead, and their role is to act as the central point of contact for any clinical management issues relating to patients under the care of our service. And that includes internally within our Fresenius Kabi departments and externally with patients, the specialists that we work with the teams in the NHS Trust, as well as other key agencies involved in their community care. These are their main roles and responsibilities that you can see here. It is a very complex role with lots of touch points with lots of key members of the MDTs, and they are that go-to person, the go-to expert for clinical queries, which they then troubleshoot for their patient cohort and action as required. Next, please. So I'm here to talk to you about development of a team, but I just wanted to mention first the structure of the service before the implementation of the team. The clinical account leads were previously clinical account managers, and they worked within separate nursing directorates. Their role was exactly the same as on the previous slide. However, they did have other roles and responsibilities that were specific to the directorate they worked in and more from a nursing management point of view. Next one, please. So that's where they sat. This separate working of the CALs did lack some consistency internally with the other roles and responsibilities that might be more specific to their directorate. And also externally, there were some differences in the way we managed the processes with the clinical teams that we work with for the patients. The service ran effectively and the quality of care was excellent. However, it was apparent that we really wanted to standardise that approach with a national team, and it was essential to do that, to continue moving forward, to drive new initiatives and overall provide that quality service to these patients receiving quite highly specialised treatment at home. The next slide, please. Thank you. So the nursing service underwent a restructure in the latter part of 2019, and as part of that new structure, the clinical account leads moved into their national standalone clinical account lead team. And that allowed a team of these dedicated clinical account leads to move away from the day-to-day management of a nursing directorate and the nurses' responsibilities and focus solely on patient management and the patient experience. It was a really positive move, and it allowed the team to work with a team of specialists and be managed by somebody who's done that role, who fully understood the complexities of the role, and it supported a review of the processes that we needed to do. So as part of implementing the team had to move out the directorate. That proved some challenges. They'd worked with their teams for quite some time. They had to change their ways of working, but they did that brilliantly whilst maintaining a quality service. I was appointed as clinical account manager and managing that team, and as part of that project implementation and the team implementation, we did a really good review of all the existing processes that were in place. We looked at standardising processes nationally, implementing some new initiatives, and changes had to be communicated then externally and internally to our key stakeholders. So just going back to this slide, just kind of emphasises that once the team were implemented and in place, they were able to focus on these responsibilities in relation to patient management and the patient experience without that distraction of other directorate specific tasks. Just on to the next slide, please. Thank you. So by having that dedicated time, we were able to look at some key projects, and the key project we really wanted to look at was contingency planning. Our National Kalea Nursing Service is really essential to making sure that our patient cohort is able to have their treatment in their home, which is their preferred place of care. And we want nothing more than to make sure that we meet their needs as well as the needs of the clinical teams who have put their trust in us. However, we also understand that as a community service, people out in the field working, getting from A to B. There are service provision can and at times may get impacted by external and internal factors. Therefore, we wanted to take control of any situations that may arise, have contingencies in place, and make sure that should the unexpected happen, we were in a good position. So although contingency planning was something that we'd always done, we recognised that we were quite reactive to situations rather than being proactive to potential situations. So what we wanted to do at the start of this project was to look at ways of being more proactive. So we split that into two areas. We wanted to review our existing SOP and develop and implement individualised patient contingency plans. So as a community nursing service, we do have a lot of potential contingencies that could impact patient treatment. Our previous SOP had focused on resource requirements rather than patient pathways, and although that ran a safe service, we really wanted to move more to focusing solely on patient management and offering specific patient contingencies dependent on different contingency criteria. So here we've just got a few of the contingencies that we do kind of face. We are trying to get from A to B, some busy areas, some remote areas, road closures, traffic, accidents can delay us getting to a patient either within their allocated visit windows or at all in some situations. We are affected by major events. Certain areas, marathons, Ironman, sports events, protests may impact us getting from A to B, and we have to kind of reallocate and reroute. We do live in the wonderful UK where there is some extreme weather at times, and being a national community service, we have to consider that. We do have some patients when we do suffer from snow, floods, excessive rain, they are inaccessible, and we have to consider the management of that. Internally, we have to look at manufacturing issues or supply issues that may impact a patient's treatment, and also nursing capacity. Nurses can and do get sick and may at times go off, and we have to consider that. And then when we did start looking at this was just pre-coronavirus. We didn't think that we would be hitting in a global pandemic, and we did start to look at epidemics and pandemics, not expecting that, but never say never. The next slide. So we were now in a good position that we detailed all the possible reasons we'd have to consider implementing contingency. We wanted to look at the different patient management options should we find ourselves in that position. There are a number of different options that we have to consider, but that won't work for our 400 plus parental nutrition patients. Not every option will suit every patient. And we recognise the significance of not having bespoke individualised contingency plans and the impact that could result in patients missing treatment or having significant disruption. So our clinical account leads in their new team work very closely with the clinical teams at the hospitals to agree patient-specific contingency plans based on the individualised patient clinical need, not just a one-size-fits-all. And that supported us should we ever need to implement contingency, whilst maintaining a consistent and safe service for these patients. Just a few possible contingencies for our patients. We can look at, simple things, changing their visit times that we agree to see them, changing the days that they potentially are seen if they're not on a 7-day service from us, look at their infusion lengths, or even potentially training patients or their carers. We look at using additional nursing capacity, moving nurses from other areas, or taking on bank agency and overtime considerations. We also have to consider that some patients are quite complex and aren't suitable for any interruption to their treatment, and the contingency for these patients is to just get them safely into their clinical teams at the hospital and just making sure that transition is a safe one. We update plans regularly in collaboration with the clinical teams just to make sure they're always relevant and up to date for the patients, because patients' conditions do change. Just on the next slide, thank you. So as I've said, when the COVID pandemic started to become quite prevalent, we were in a position where we'd already started with these contingency plans and looking at these, and we understood what options were available. Early in 2020, the nursing service started looking at potential impact that the pandemic could have on our patients, and we recognised that our patient cohort were those high risk and extremely vulnerable patients, and we therefore saw an urgent need to start to implement these processes as soon as possible. So early in the first lockdown, our clinical account leads, again, being experts in their patients and knowing their patients clinically, were able to meet again with their clinical teams and look quite closely at what other options were available for these patients should we need to implement contingency, but also being very proactive. So there were two key areas we looked at. We had the option of patients training or having a carer trained. Some patients had been offered training before but hadn't actively taken this up, but at this time they were really, really keen on taking up training or having a family member who may have been at home at this time training to take over their care. This could be all of their care, part of their care, long term or short term, but essentially we wanted to reduce the need for nursing visits. We also then considered what patients were suitable to have their infusions over a longer period. The majority of our patients are parental nutrition patients, and a high percentage of those do have twice daily visits to disconnect their parental nutrition in the morning and connect it in an evening. By increasing the infusion time and disconnecting and connecting at one visit, we were reducing the need for nursing visits. And our overall aim to reduce these visits was to reduce footfall in the patient's home, was to reduce the contact they have with the outside. A lot of them were fully isolating and therefore reducing the risk to them. And not only did it reduce and protect our patients, but it also protected our nursing workforce, which we had to take into consideration during the peaks of the pandemic. So thanks to the implementation of this nursing team, this clinical account lead team, and the contingency plans that we'd already started being very proactive with, when COVID came along, our contingencies were already in a good position and we were able to get on top of that very quickly. So next steps for our team, we're just about to roll out a clinical account lead team SOP. We've had an increase in heads since the team started and have a dedicated biosimilars clinical account lead. We're constantly reassessing our contingency plan management and updating that as required internally and externally with our clinical teams. And we do work very closely with the clinical teams at the NHS Trust that we work with to make sure that we're ongoing safe patient management. That's the end of my presentation. If there's any questions, thank you.